And now it's my opportunity to discuss risk assessment in the area of novel therapies as our next topic. And most importantly, which factors are relevant. Here are my disclosures. So this is a curve that we've all seen quite a bit, and what I really want to sort of point out from this is not the usual improvement in outcomes that we really experience over time, but really want to sort of focus on the variability in outcomes that we have with our patients. So we have a huge variability in how our patients are going to do with their CLL. And over the years, we've actually generated a very, very long list of prognostic markers, and I've actually stopped updating this list as I've completed the page. But this list continues to increase. And the question, of course, is, these prognostic factors teach us about the biology, and so they're helpful. But more importantly, what are we going to use clinically to take care of our patients? So we have our 4 classic prognostic markers that are available in the clinic. So we have IGVH mutational status, interphase FISH, CD38 expression, and ZAP70 positivity. And these have all been very well characterized and defined over the past 20 years and really do play a role in helping us predict how patients are going to do. But none of them really do what we need them to do. And it's the Rye classification that really is the single most important tool we have, as Dr. Rye sits down in the back. And it really is the one tool we have that tells us not only, who we need to treat, but when. And I think that's a very important thing to acknowledge because all these other prognostic markers really don't give us the necessary information to make therapeutic decisions, outside of a few exceptions. Now, one of the important questions to keep in mind is when we talk about prognostic markers is what is the setting in which we're discussing these factors? And I want to point out that those prognostic markers that I showed previously were time to treatment and that they were in the era of novel chemotherapy, in the era of chemoimmunotherapy. So of course, when you start discussing prognostic markers and you start talking about the era of novel agents, things are going to change. What's also going to change is what we're using as our endpoint. So I'd like to point out here that with the use of Ibrutinib, in terms of response rate, and that's the important thing to keep in mind, in the terms of response rate, none of these prognostic markers have any ability to predict outcome. Now, of course, what's really most important for everyone, and most importantly for our patients to keep in mind, is that the response rate is not nearly as important to our patients as progression-free survival. Because ultimately, if a patient's taking a pill a day and feels fine, it doesn't really matter where their disease is. So I'd like to emphasize that when we look at prognostic markers, we really need to look at response. And what are we assessing with our prognostic marker? So response rate, time to first treatment, response depth, time to next treatment, overall survival. Those are really the important question that everyone needs to ask whenever you look at a prognostic marker. The second thing, of course, is to look at what the agent that is being used. So when we talk about MRD as a predictor of outcome, that's usually based upon FCR chemotherapy. And based upon the German CLL study group, CLL4 and 8 trials, we definitely have some very good data supporting the depth of MRD negativity as a predictor of outcome. Now, the important question that's going to ask is, what are we going to use that information for? And currently, we have no data helping us to determine what to do with that information. I'd like to point out that there was a trial that was done taking patients who had gotten fludarabine and rituximab and gave them alemtuzumab afterwards. And in those patients who were in a complete response after FR, they then got their alemtuzumab. There was a marked increase in the risk of death due to infections. And so it's always important to make sure that if we're going to generate a prognostic marker or some data point, that it be something that we're actually able to use. So we talk about Ibrutinib here, which of course, because of the necessary lymphocytosis, really sort of changes the paradigm. But for all future parts of this discussion, I just want to emphasize that Ibrutinib could really be substituted with any of the novel agents, so idelalisib, venetoclax, and of course all the agents coming down the pipeline. So just to emphasize, all prognostic markers need to be taken in the perspective of what the treatment is as well as what is the assessment we're looking at. So here's the FCR 300, and these are 300 patients treated with FCR in basically consecutive sequence at MD Anderson. And when you look at these curves, we have the PFS curve here, and we have the overall survival curve here. Everyone always focuses on this plateau at the end, and everyone says, not everyone, but a lot of people say that about 35% of the patients might actually be cured of their CLL through the use of FCR. The problem is, when you look at that plateau, all of a sudden you can see that about 70% of that plateau is going to be comprised of patients who are mutated immunoglobulin genes. Now, some people are going to say that all of a sudden, if you're mutated and you get FCR, you have a 70% chance of being cured, but that has to be weighed against the idea that 30% are not and will need additional therapy, and then you have to contend with the toxicities of chemotherapy. So the risk of Richters, other hematologic malignancies, most notably MDS and AML, as well as other cancers. And so these are all very important things to consider whenever we think about using prognostic markers. So I'm going to talk about the B-cell receptor-associated kinases, and I just want to go through a quick list. So we have SYK, which was the first one targeted. Second was Bruton's tyrosine kinase, and you can see Ibrutinib, CC292, which is no longer in commercial development. Acalabrutinib, which should probably, or which we might expect to be approved very shortly for mantle cell lymphoma, and Tirabrutinib, which is the ONO4059, which is actually now GS4059. And then we have the PI3 kinase inhibitors. We have Idelalisib, Duvelisib, and Umbralisib. So in talking about our response endpoint, I want to focus on progression of the CLL. And there's really two ways that CLLs progress. And in general, when you talk about why patients need to come off treatment, and I hate using the term the patients, it's really the treatment fails the patients. The first and most common is going to be progression of the CLL. And I'll talk more about the relative contributions of each of these in a moment. But the five are going to be progression of the CLL, or transformation to a more aggressive histology, aka Richter's transformation, infectious complications, adverse events, and then secondary cancers. So when we look at progression on Ibrutinib, we talk about really two types. So there's the first type, which is a patient who has CLL, responds, and then progresses with CLL, and we're going to call that CLL resistance. And these most commonly are actually, and I'll speak to this in a later talk, are mostly going to be driven by single base pair mutations in BTK or PLC gamma that really seem to enable the cells to survive Ibrutinib. The second progression is actually going to be a transformation. And this is problematic in the sense that the novel agents really don't work in our rapidly dividing diseases. And there's a lot of potential reasons why. Which one is correct, we actually don't know yet. But I'd like everyone to focus on a CLL versus a Richter's mode of transformation. And one of the things, of course, that's going to be important is, can we identify these patients ahead of time and then use that information to change outcome? So here we have our Ibrutinib 5-year outcomes curves, and this is actually the phase 2 Ibrutinib trial, and these are data that were presented at ASH last year by Susan O'Brien and will be coming out shortly in manuscript. And what I'd like to point out that when you look at the top curve here, which is a treatment-naive group, and then you look at this bottom curve here, which is a relapse refractory, we clearly have a very differential difference in progression-free survival. So the first question we need to ask ourselves, what is it about these versus these that's going to help predict outcome? And when we looked at these patients, the thing that first came to mind was interface FISH abnormality. And what you can see here is, at least in the relapse refractory population, primarily because in the treatment-naive group, we really had too few patients to really make a lot of assessments. But in the relapse refractory population, interface FISH very nicely predict outcome, with deletion 17p and deletion 11q really faring far worse than the others. And I look at my patients who are on Ibrutinib, and I think to the fact that the 5-year progression-free survival may only be about 20% for that patient with 17p deletion. And for that patient with 11q, it's 33%. So obviously we need to do more. And that's really what becomes very important. But one of the things that we're actually now being confronted with, and this is sort of one of the important take-home messages, is when you look at more recent data, and these are data from Tom Kipps, looking at an integrated analysis of 3 different phase 3 trials, so HELIOS, RESONATE, and RESONATE-2, you can really see that interphase FISH is no longer prognostic. So here we're looking at the 11q deletion curve on the ibrutinib arms, and you can see that patients do equally well with or without 11q deletion. Now, this is a mix of chemotherapy and non-chemotherapeutic, ibrutinib plus chemotherapy versus single-agent ibrutinib, but by and large, controlling for that, it really looks like 11q deletion no longer predicts for an outcome, poor outcome. And then this is also reflected in actually the long-term follow-up of the RESONATE study, which is actually now available online with Jen Brown as the first author. And what you can really see is actually the top curve, the top line on this represents the 11q deleted patients. And you even have the 17p deleted patients really not faring any worse than the group overall. So the questions that really arise from this is whether the questions are that we either are dealing with patients who are not yet gotten far enough out, and so we're going to start to see a differential split of the curves. But if you go back to the original curve, we were seeing differences earlier on. So then the other question becomes, well, what else is going on and what else is differentiating these patients? So here we are confronted with really not knowing what is prognostic, and I'm hopefully going to give you a few answers to everyone as we go through this. Now, when we talk about going back to our modes of progression, we have our patients who here develop a Richter's transformation and actually come off therapy, and here we have our patients who are coming off therapy for progression of their CLL that is due to a CLL resistance. These are data from OSU looking at all patients who have come off ibrutinib, and here, of course, are the adverse event patients. But I'd like to just focus on these 2 curves here, focusing on the fact that early discontinuation or early disease progression, which is what I'm going to use from here on, is actually more likely due to a Richter's transformation. And you can see there's really a plateau at 2 years. And this speaks to the idea that it's probably either biology or pre-existing or pre-existing Richter's transformations before therapy starts that's likely driving the transformation. Because when you look far out, we actually see a very nice plateau, suggesting that the patient's either going to transform or not transform. And therefore, if we don't see it within 2 years, patients might consider themselves free and clear. So what are those biological risk factors are going to be very important. And what I'll speak to later on is actually what are the risk factors that are important for this part of the curve too, which really starts to rise at year 2. So looking at the variables associated with ibrutinib discontinuation, focusing really right now primarily on the transformation and the CLL components, you could see that complex karyotype and c-MYC for the risk of transformation really stand out as most important in this multivariate analysis. For CLL progression, complex karyotype, a deletion of 17p in age less than 65 stood out as negative predictive prognostic values. So all of a sudden, we have very specific and different values than what we're traditionally thinking of when we look at this huge array of over 70 different prognostic markers that I listed in the beginning of the talk. What I would like to just point out also is this idea of complex karyotype, deletion 17p, and even possibly 11q, really speaking to a mutator phenotype, and that these are probably events occurring earlier on, long before the patients are starting treatment, and really speak to genomic instability, and that the ability of these cells to undergo other mutations that will give rise to those changes that will lead to a Richter's or to a cysteine 41 serine mutation that will lead to BTK resistance, all are taking place long before we begin to treat our patient. And this is actually becomes very important because the survival in our patients after Ibrutinib discontinuation is actually really quite poor. And this curve is certainly changing in the era of additional agents that are coming to light. But you can see here that when we talk about our CLL progression and our risk of transformations, that patients really do quite poorly. So just focusing on the CLL progression right now, I'm going to focus on complex karyotype, the deletion 17p, and the age less than 65 as being indicative of a poor outcome. And you can see here, and these are data from the same study, looking at age and immunoglobulin G mutational status. And what I want to point out from this is while none of these factors predict response, right? So I showed you the response rates. None of our prognostic variables had a predictive outcome on response rate. All of a sudden, when you start looking at PFS, things change dramatically. And in looking at these two here, we actually see that the curves really split later on. So by the original analyses, the prognostic markers had crossed the threshold of futility and were deemed to be not prognostically significant. But if you do a landmark analysis, you get a very different response. And it's important to keep in mind that, so here, age remained prognostically important, whereas immunoglobulin G mutational status in multivariate analysis was no longer significant. So here we have sort of the idea that with the age younger than 65 as being a poor predictor, all of a sudden a prognostic marker that doesn't come to light until later on, but does sort of predict who our patients, which of our patients are not going to do as well. And looking at the group from OSU's data, you could see for patients who are over the age of 65, have no complex karyotype, and no deletion 17p, their risk of CLL progression at 4 years is 1.9%. For patients younger than 65 with complex karyotype and a deletion 17p, which mind you is certainly a small group of people, we're talking about a risk of progression of 44%. So we all of a sudden have tremendous split of the curves, and really the idea that we might one day be able to look at a patient and say, you're going to do very well on single agent Ibrutinib indefinitely, and this could very well all be that you need. But looking at the second patient, we may say, obviously this is not going to work for you. We need to do something different. And the question, of course, is what do we need to do different? And I'm going to talk about that in a moment. But speaking specifically to Richter's, which from my perspective represents an endgame for our patients. Richter's are very hard to treat. We actually have to use very aggressive chemotherapy that's very toxic and really becomes very problematic for our patients. So the overall risk of Richter's, of course, is about 1% per year. But of course, if we're able to actually choose the bad actors, we can actually make one curve get a lot worse and one curve get a lot better. So when we look at the two complex karyotype, the two prognostic markers I already spoke to, complex karyotype and MYC abnormalities, I want to add 3 more to that from other data out there. One is the immunoglobulin gene 4-39, which is a stereotyped receptor subset. So I think it's important to keep in mind that not all 4-39 are going to have a bad outcome, but a subgroup of those will actually have stereotypical B-cell receptors, or stereotyped B-cell receptors and have a poor outcome. I suspect that these are going to be the IgG expressing 4-39 cells, and this actually relates to data generated in the mid-90s by Nick Chirazi. Then, of course, we have trisomy 12, deletion 11q, and TP53 disruption, and Notch1 mutation. And looking at 4-39, you can see here the relative risk of developing Richter's transformation if you're if you're 4-39 positive versus negative. And you can see here that we're getting up to about 40% at 5 years. And here, looking at Notch, you can see that once again we're at about 40% at 5 years for the Notch mutated versus the non-Notch mutated. And then, of course, it turns out that these are additive. And so here we are at 5 years at 100% for patients who are both having a 4-39 stereotyped receptor and a Notch mutation. So if you have a patient in front of you that says, who is 4-39 and Notch mutated, you could be certainly assured that you're going to need to do something differently to give this patient a long-term outcome. And then the one other factor I want to point out, which really don't have a lot of data on currently, but what is sort of, I think, very important, and what we'll see more and more of as patients live longer and longer after their frontline chemotherapy. So the idea is that my patient who comes to me relapsed after FCR as a giant lymph node previously would have died after having a poor response to bendamustine or a poor response to fludarabine, now gets ibrutinib or venetoclax or idelalisib and has a tremendous response, except for that one lymph node chain underneath, the diaphragm, and all of a sudden, 6 months later has a massive Richter's transformation. So I suspect we may see the numbers of transformations diagnosed increase as patients live longer, but you can see here that purine analog plus alkylator does significantly increase the risk of a Richter's transformation. So these are the risk factors that I believe really are most pertinent in 2017 to determining how a patient's going to do long term. And what I think is most important for us to do is to figure out now how to use this to apply our therapies differently. Thank you.